Hello, welcome to this video on cranial cervical instability. This is number 2 in a 3-part series. Last time we looked at atlantoaxial instability. Today we're going to look at cranial cervical instability, and our third section will be on exercises and treatment. I hope you enjoy this. There are some technical words in here and technical terms for the therapists who might watch this. I will try and explain for those of you who are just hypermobiles and may not know what these terms mean to the best of my ability, but hopefully there will be something for everyone in here. Right, so we are looking at cranial cervical instability today. So where does this take place? This takes place right at the very top where your skull, the base of your skull, your occiput, joins the C1, which is the very first vertebrae of the spine. So last week we looked at the first cervical vertebrae and the second cervical vertebrae. So we're now jumping a step up above. So the principal movement at this joint will be flexion and extension, which is you're nodding your head yes. That would be your flexion and extension. And so this area of the cervical spine, as we know, we can nod our head down and back quite freely, and there's a lot of movement there. And we also have lots of rotational movement between the vertebrae, the C1 and the C2, because we need to be able to see all around us for safety. So because there isn't a lot of stability from the actual surface of the joints, we are very much reliant on ligaments and musculature. So there are several ligaments involved. The head is a very heavy part of our body, and the most heaviest part of our body. So we need good, strong ligaments there. And unfortunately, with connective tissue issues, we know that the ligaments are not as strong, so we don't get that lovely stability all the time that we need. So I'm not going through all of the ligaments to show you today, but I'll just name them off for the people who are therapists and might be interested. So these include the ligamentum nuchae, the alar ligament, the apical ligament, and the lateral atlanto-occipital ligament. But the two main for that flexion and extension, the ligaments would be the posterior, which is the back, and the anterior, which is the front, atlanto-occipital ligaments and membrane. So what actually happens with cranial cervical instability, and why is it a problem? So we have here images of your C1, C2. So this is the top vertebrae where it meets your skull, and you can see where the skull would sit and slide nicely. And then on the C2, which is the one that comes up and meets the C1, you can see there's that projection on the top, which is what we call the odontoid peg. And this gets pushed up. You can see through the hole. Unfortunately, when we have excessive flexion in that top cervical vertebrae, then that peg can actually cause pressure on the brainstem and the upper spinal cord, and it can create traction also on the vertebral artery, possibly also alter the outflow of the venous or the cranial cerebral spinal fluid. So you get a block where actually the skull, the fluids within a skull, both the venous fluid and the cerebral spinal fluid, can't drain out. So that's not a great thing, because we don't want to have a buildup of pressure in the skull. So symptoms of CCI are slightly different than AAI, where we discussed there was not always neurological symptoms with AAI. But with your CCI, you would expect more sensory changes, such as weakness of the arms and legs, hyperreflexia, so you would be overactive in your reflexes, a positive Babinski and Hoffman sign, which is testing the central nervous system. So those two tests would be positive, because we know would be affecting the brainstem, so not peripheral nerves, but central nervous system. And possibly an absence of abdominal reflexes. So other problems can include headache, neck pain, sphincter problems. So sphincters are what helps close off when you want to not either pee or poo, basically. Emesis, vomiting, altered sexual function, altered menses, dyspnea, difficult or labored breathing, dysphonia, changes in voice such as raspiness or hoarseness, syncope, which we talked about last time, which is a fainting when you stand up, and gait changes, so altered changes when you walk because of the weakness and the signaling isn't getting through normally. So if you have all of these symptoms together that we just discussed, then you are considered to have something called cervical medullary syndrome. So how do they diagnose cranial cervical instability? So there is lots of controversy and questions about imaging, upright imaging or not, whether it's a valid diagnosis for this, but I'm going to take you through what they use. We tend in the UK, it's very difficult to get these images done for cranial cervical instability. They're much better in America, although there's still only a limited number of people who will take people on with cranial cervical instability issues. So there are 3 measurements that they try to take to diagnose the condition. The measurements are all done through imaging. So the first one is called the clivoaxial angle. And this is an angle between the clivus. So I've given you an image on the top, and you can see in red, it says clivus. And this is the base of the skull you're looking at. So the hole in the middle, which is called the foramen magnum, is where the spinal cord comes out, and the brainstem comes out or sits just above. The clivus is just there, and the clivus axial angle takes a measurement from there, and it comes down to the back of the dens. So the dens is the peg that stands up that we talked about. So it's a bit confusing because there's 2 different names. They always have different names for things. So it could be the odontoid or it can be the dens. So an angle, when you measure, and you can see the bottom image, how they measure the angle of 145 degrees to 160 is considered normal. Anything less than that, so 135 degrees, is deemed to be pathological. And this means that the cranial cervical angle is more kyphotic, so more forward into flexion, and acts as a fulcrum over that peg. And that's where we get the compression of that peg coming up into the brainstem. So the second measurement that's often taken is called the Harris measurement. And this is the distance from the basion to the midpoint of the anterior margin of the foramen magnum to the posterior axial line or the odontoid. So I have given you images because that's a big mouthful. Again, if you look on the right, the foramen magnum is in pink. And again, that's the exit where the spinal cord can come down into the spine. And then it comes down to the odontoid, which is the peg again. So you can see in the imaging, they take a moving image here. So they will take someone moving into flexion and moving into extension, because you would expect when they measure this that there will be virtually no movement. So if there's a translation or a sliding movement between these points of more than 1 millimeter, then it warrants evaluation for stabilization. So it means it's sliding back and forth, which it shouldn't do. So the last measurement is called the Grab-Mapstone-Oakes method measurement. And this assesses the risk of clinically significant ventral brainstem compression. And has been clinically, statistically correlated within clinical outcomes. So if you look again at the image, I've got you again an image of the foramen magnum, and down below you can see where they take that line coming down. But then you've got this perpendicular line, this measurement, again, looking at the angle. And if it exceeds 9 millimeters, this line, then it would suggest a risk of ventral brainstem compression. So you can see that the greater the angles are, and the bigger that measurement would be, the more compression there would be into the spinal cord or the brainstem. So symptoms, CAI symptoms, can be present in many other comorbidities, which makes it very difficult. It can be really challenging to diagnose this condition if you've got lots of other things that create the same symptoms. So it's not uncommon to see both craniocervical instability and atlantoaxial instability together. And there are a few things that they look out for that can be a sign specifically of these conditions, because with things like mast cell activation and dysautonomy and all of that, you can have a lot of the similar symptoms. This becomes more specific when it's subjective, but it's more specific in helping to diagnose and to narrow down the criteria for actual cervical cranial cervical instability and AAI problems. So often people with instability will talk about the feeling of difficulty of holding their head up. It just feels too heavy to hold up, and they feel like they're bubble-headed. So if you think about those dogs that used to be in the back of the car and the head that nods, there's that kind of feeling of that always moving around on the top of the spinal cord. They will have problems such with traveling, such as potholes in the rolls or things where the ground moves from underneath them. So these things will provoke symptoms. And they'll have apprehension at the end of range of cervical movement. They won't want to go there. So strength will be reduced and very poor, and their ocular, motor, and proprioception skills are often diminished. So symptoms, strangely, can often be present during mid-range, not end range. So there is controversy as to the importance or validity of the end range imaging. There are gaps in evidence in the radiological tests for CCI and AAI, where initially these measurements that we talked about were designed for other groups of people, really people who had trauma, so people who were having car accidents and big traumas. The measurements were more about instability for that group of people, but not the hypermobile. So there is question as to whether you took a whole group of people with, say, Ehlers-Danlos syndrome, and you gave them imaging and you asked them to move, whether they would all show greater than normal measurements, but not all of them would necessarily be symptomatic. So there are different opinions throughout the medical community on whether someone should have surgery based on the evidence offered at the moment. So in the UK, I don't think there's anyone doing surgery. If there is, I probably wouldn't go near them because they won't be doing a lot of surgery and it will be incredibly risky. There may be one person, but generally speaking, the surgeons who do more surgery in this area are coming out of America and one in Italy. Treatment should always be exhausted before embarking on surgical intervention. And the surgeons would say this as well. They do not like doing this surgery unless it's absolutely necessary. Hopefully, there is a real interest in this, and there are more people researching it now. So there will be more research to find a more straightforward pathway for those who suffer from CCI and AAI. So thank you for listening. This was really about explaining about the conditions, and hopefully you will tune in for the next in the series where we look at the way that we offer to stabilize the cervical spine and the interventions which are offered and are the best way to go at the moment.